Do you want to know, Dr. John?
I don't, because I'm on my phone.
Oh, good morning, everybody. We want to thank you for all hopping on and joining us. Dr. Peepcorn and Dr. Robinson and Jennifer Clary with our infection control team are here with us this morning to give a presentation on measles. So we're really excited that they've put this together, and I thank them for helping me this morning. There is CE credit for those of you that stay for the entire presentation and complete the evaluation at the end. If for some reason you have some people that weren't able to hop on this morning, feel free to email me and I can send you the recorded presentation. Once they complete that and the evaluation, I can still send them the certificate. So even if they can't join us this morning, we can still get it done for them. So without further ado, I will go ahead and turn it over to Dr. Peepcorn and get it started. Thank you, guys.
Good morning, everybody. Kelsey, can you hear me?
Yes, ma'am.
And you can see my screen?
Yes, ma'am, I sure can.
Okay. If there's any issues as before, y'all just interrupt. So as Kelsey said, we're going to talk a little bit about measles. We thought this was a good opportunity for everyone to kind of have a refresher on measles, as most of us are probably not super familiar. I just want to put a disclaimer that I am by no means a measles expert. So that's one of the reasons I did ask Dr. Robinson to join as well as Jennifer. So I'm the medical director of the neonatal ICU here at UMC. Dr. Robinson is the director of the newborn nursery and family care unit. And then Jennifer runs our infection control program. So I'm hoping between the three of us, we can give you guys some good information on measles itself. And I tried to take as much information as I could find and put it into um, kind of organize it into a way that hopefully makes sense and is easy to follow. And then there should be plenty of time at the end if we want to talk about, how are we managing patients here at UMC to kind of give you some ideas and things to think about, and for you guys to ask questions while we're all here together. I'm going to talk a little bit about the outbreak and where it stands as of yesterday evening when I looked at the latest data. We'll talk a little bit about just measles in general, immunity and vaccine status. We'll talk about what that infection looks like, as well as some of the complications that we, may have heard about or need to worry about. And then we'll spend probably the majority of this discussion kind of talking about what to do if you have someone who has suspected measles. How do you test them? How do you treat them? How do you manage them? And whether that's going to be in your local hospital setting, in your clinic, at home. It is a little bit complicated sometimes, I think, because there's a lot of different variables depending on the patient's age, their immune status, the time from their exposure. So we'll try to break all of that down into something that's simple and easy to follow. And I believe that Kelsey is recording this, or that this lecture and slides will be available for you guys to refer back to as well. So let's go ahead and get started. Okay, so our current outbreak that we are in, as of yesterday evening, the health department was reporting 198 cases since late January. I believe they update the numbers on Tuesdays and Fridays. So I haven't seen an update for today since it's so early this morning, but I believe that's when they put their updates out there online. We've had about 23 patients hospitalized, 64 patients in that 0 to 4 young child age range. 2 fatalities. So I think the second one was just within the last week or two. The first fatality, I believe, was a school-age child who was unvaccinated, no underlying conditions. And the second one I don't have as much information on, but I believe it was an adult, also unvaccinated. For when the health department is talking about vaccinated versus unvaccinated for this outbreak, if you've had at least one MMR vaccine, that is considered vaccinated. So just a piece of information. It doesn't necessarily mean people who are vaccinated have had both immunizations as recommended. But that being said, the vast majority are still unvaccinated, or at least unknown status. And at this time, there's been 5 reported cases in what we're considering vaccinated individuals. So I think that puts us somewhere around 75 75 to 80% unvaccinated or unknown at this time. So there was an outbreak about 10 years ago in an Amish community up north. And so I thought it was interesting. And I went back and looked at that outbreak because it seems ours is kind of settled or started in our Mennonite community. And so there's some similarities, I think. It's a close-knit type community. It's a highly unvaccinated population in those communities. And so I went back and just to kind of compare a little bit to what their outbreak looked like and hoping that maybe it would give us some idea of what we're going to see moving forward or what the timeline may be for where we are here in Texas. So there was about 383 infected. At that time, it was the largest outbreak in 20 years. The median age was 15, so a lot of children, as expected, were infected. They had 9 hospitalized, but no deaths, thank goodness. And again, a very, very high percentage of unvaccinated individuals that were infected. It was a really good study in how to do a really good job at limiting spread. And they did that by they vaccinated a lot of those community members who weren't previously vaccinated. They also, were really, really good at kind of social distancing and avoiding those social gatherings. And they were pretty judicious about their quarantining and isolation of patients. And so they really did a pretty good job, I think, given the situation, to keep it fairly contained, and it lasted about 4 months from March to July. So I don't know if we can expect the same timeline. I think we're probably, if it started in late January, we're, somewhere around six weeks in. So it'll be interesting to see once we get out of this outbreak, if it kind of followed a similar timeline. So measles is caused by the morbillivirus. It's highly, highly contagious, and it's an airborne virus. So obviously, it's going to be spread through coughing, sneezing, talking, and those droplets can spread and they can live for several hours, so up to 2 hours. So you may have heard if someone has been in a space, that space is considered to have measles virus in it and active for 2 hours. Um, so you can see it's a very easily spreadable. If you come into that room after that person has left and you touch surfaces that have had measles virus on them and you touch your face or something like that, you are going to possibly inoculate yourself and continue to spread that virus. It can be spread to the fetus during pregnancy through the placenta. It can be spread to the baby during delivery if the mom is positive in those close quarters. It also can be spread during nursing. Now, it does not get passed through the breast milk, so we do want to still provide breast milk to those babies whose mothers have measles. But if you are nursing or breastfeeding that baby and the mother has measles, that is extremely close contact, obviously, and so very high risk of potentially spreading that infection to your infant. The infectious period is considered from 4 days prior to the onset of rash to 4 days after the onset of rash. After 4 days, once the rash has started, that person is no longer considered infectious. When we talk about immunity, there's a couple ways that someone can be described as having immunity to measles. Obviously, the one that we're most familiar with is going to be receiving those 2 vaccines of MMR. The first dose, as most of you know, should be given around 12 months of age, and then the second dose typically is given at 4 to 6 years of age. So there's 2 doses to this vaccine just to help ensure and boost effectiveness. After the first dose, it's thought that people are going to be about 93% of the time are going to be have a good immunity to measles and be well protected, but there is that percentage that don't respond the way we would want them to after 1 dose, and so that is why that second dose is recommended. After the second dose, the effectiveness is thought to be around 97%, so pretty high. You can give that second dose earlier than 4 to 6 years of age, especially when we're in a situation where we are right now with our outbreak. So you can give it earlier. It just needs to be 28 days from that first dose. The second way to ensure immunity would be through laboratory confirmation of immunity from the vaccine or from a past measles infection. So you can do lab testing to confirm that. We'll talk a little bit more about that later. And then the last way would be anyone who was born before 1957 is going to be considered immune. So the vaccine was licensed in 1963. So obviously, if you were born before 1957, there was no vaccine available, but it's estimated that somewhere between 95 to 98% of all individuals born before that year are going to be immune through just natural infection. So those are going to be the ways that we can define or confirm immunity in a person. Just a little bit more on the measles vaccine. It's a live vaccine, so we do not want to give that during pregnancy for the potential risk of causing an infection in the fetus. Again, it is safe to give while breastfeeding. So those of you that care for pregnant mothers, you probably know if they do not have not had their MMR, or they are not vaccinated, you want to give them that vaccine after they deliver, ideally before they leave the hospital. The other thing that's important to know is we talked about giving that second dose early. You can also give that first dose early, especially again, we're in a situation where we have an active outbreak in our community. So we can give it to younger children than 12 months of age. They do need to be at least 6 months of age. If you give it earlier than that, they may still have some passive immunity from mom, and those antibodies can kind of conflict with that vaccine and not create the immunity that we want. But it is really, really important to note that if you give that vaccine early, you give it in that 6 to 12 months or before 12 months age range, in order for us to fully ensure that that child develops full immunity moving forward, you still want to give 2 MMR vaccines after 12 months, just like our vaccine schedule would say. So those children would end up getting 3 MMRs total if you give it early. So a little bit on the measles infection. Most of us probably haven't seen measles before now. We haven't had a lot of that infection in our community with vaccines. So just a refresh on what that looks like. So the symptoms typically are going to develop between 10 to 14 days after that person's initial exposure. The early symptoms are going to consist of high fever and kind of cold symptoms. So I remember when I was in school learning about the 3 C's of measles symptoms: cough, coryza, which is just a fancy name for runny nose, and conjunctivitis. So high fever in the 3 C's is what we see first. Again, often kind of just looks like a regular cold. And then usually you're going to start to see these Koplik spots. So Koplik spots are kind of considered a diagnostic feature of measles. There's these small white, sometimes bluish hued spots on the inside of the mouth. You can kind of see a good picture of it there. And then a few days after those cold symptoms and after the Koplik spots develop, you're going to start to see that rash, that classic measles rash. So this morbilliform rash is what often referred to as. The classic one, I think, is these flat red spots, but it can be some small raised bumps. It classically is going to start at the head or neck, often around the hairline. I think that's kind of the key features when you start to see this rash. It's not generalized everywhere to start with, but starts on the head and neck, and usually will spread over the next few days down the body and all the way out to the hands and feet. It can become confluent, so you can kind of see on these pictures here of the head and neck where it's starting, and then it's kind of convalescing together, and you have areas that just look bright red where that's kind of become confluent. It will slowly start to fade, kind of goes to a brown color and then disappears. And then in some instances, you may have some peeling of the skin as well. A couple other pictures that I just found online, I think just kind of just show some diversity of the rash. The top left there, you can see that infant. His head and neck are almost completely red because of the confluency of the rash, but you can see how it's kind of spread down his back and onto his arms. The top right is another infant. You can see the beginning of the rash, and then as it kind of progresses and spreads across the head and face. The bottom left picture is going to be one of our darker skinned individuals, well, maybe the redness isn't as obvious, and this is more of that like bumpy rash that you can see on the forehead there. And then the bottom right again is just another infant with some of the rash on the cheeks, and then kind of how it looks again coming across the extremities. So complications, I think this is what we always worry about. There are some very significant complications that can occur with measles. They tend to be seen more in the extremities of age. So infants and young children and adults are more likely or more at risk for complications than maybe kind of our older children, adolescents. We don't see it as often in that group, although you can. What we usually think about when we talk about complications with measles are going to be things like pneumonia and encephalitis. There's a specific type of encephalitis that's called subacute sclerosing panencephalitis. This is unfortunately more common in infants or in children that obtain the infection during infancy. And it is um, subacute. So it doesn't, it can be 4 to 10 years later after the acute infection. So you can see that can be maybe very difficult to tie back to this measles infection if you don't know about it, and can make that link. But it's a really, really unfortunate degenerative neurologic disorder. Often starts with some intellectual decline and some behavioral changes that then progress to seizures, dementia, and possibly death. For those children that have measles in infancy that are more at risk, it also tends to be more severe. It tends to have a shorter latency period of those 4 to 10 years. That's going to be shorter and more rapidly progressive. So just a really devastating complication to measles. Pregnant women are kind of the other group that we worry about. You can also probably include, immune compromised people in this high risk for complications. But for pregnant women, there's also increased morbidity and mortality. They're more likely to be hospitalized. They're more likely to develop pneumonia and have a higher mortality rate. It does increase the risk of preterm births and therefore low birth weight infants. Because of that, you're more likely to have NICU admissions for those patients. They tend to have longer NICU stays. The literature's historically been a little bit conflicting on increase in fetal loss and congenital anomalies, but I think we feel confident that it most likely does not cause congenital anomalies. I think that was really thought of because when you think about other similar viruses, we do know there's congenital anomalies in some of these other viral infections that can be contracted congenitally, but or prenatally. But I think for the most part, the literature now is really saying that those probably are not common or not caused by measles. When we talk about exposure and exposure risk, what does that mean? So someone is considered exposed by airborne droplets in a shared space, and we'll kind of talk about what that means, for up to 2 hours. Again, they can last for 2 hours after that space is vacated by the infectious patient. So if there was someone who had measles in your ER waiting room and they leave and someone comes in 30 minutes, an hour, hour and a half, 2 hours later, they have been exposed. What does the shared space mean? Well, I think it's easy to say, like if you're in the same room, you're in an ambulance, maybe you're sitting next to somebody in a waiting area, it's a smaller space and we're all sharing it. But keep in mind, it can be a much, much larger area that maybe shares a common air handling system. So in your ER, where you have a separate waiting room and maybe you have a triage area, and then you have separate patient rooms, and then you have where your healthcare workers are working and charting, those are all separate rooms. But if they all share a common air handling system, that can be considered a shared space. So just keep that in mind and kind of know what your facility has. We can divide exposure risk to low risk and high risk. So low risk would be, the suspected patient has a mask on. They're transported quickly to an isolation room or an air room, but maybe they were in the triage area and they were transported down the hall, but they were wearing a mask. And it was very quick. They weren't in those areas very long. So that exposure risk is considered low, but of course it's not zero. So high risk is going to be you have susceptible people, so no evidence of immunity, um, especially if you have someone who is, providing care or is face to face with the person who has measles or is considered to have measles, and everybody's unmasked. That close, intimate, face to face contact without immunity and out without mask is going to be very, very high risk for that person. Again, it could also be persons that are sitting in the same waiting room and the person with measles does not have a mask on. That's going to be a high risk exposure. So what do we do with these patients that come in with suspected measles? You're going to want to do this as quickly as possible, get a mask on them and isolate them. Ideally in an airborne isolation room or air room. If that's not available, you want to get them to some place that maybe if there's a facility close that you can get them to. The other option is just to put them in a room with a mask on and keep the door closed. if that's the best that you have available, then that is what you want to do. Just try to isolate them and keep them contained as much as possible. For infants or small children, that maybe it's going to be difficult to keep a mask on. We've had situations where I've heard people using like covered cribs, where you can kind of put them in a big crib and put the covering over it. I've heard people talk about using oxy hoods, especially for an infant that's laying down and kind of just covers their um, head and neck. So you may have to be a little bit creative for those small children and infants that it's going to be difficult to keep a mask on. So that's the first thing you want to do. Um, it's recommended that if there are family members with that person, that they are also wear masks until their vaccination status or illness status is determined. And then for those of us that are caring for these patients, um, standard precautions, very similar to COVID, N95, gown, glove, face shield, all the things that we did when we had COVID, that's kind of the same precautions you're going to want to take. Some general information about testing for measles. So there's two ways to test for measles. One is going to be a nasopharyngeal swab or a throat swab for a PCR. And both these are going to be sent out to the health department. So it's not quick. It's there's a turnaround time, somewhere around 5 days or up to 5 days for both these testings. So that's the swab. It's a PCR. The other is a serum or blood test for IgM for measles. Again, send out to the health department. This one you do need to be careful about because it's most sensitive 3 or more days after the onset of the rash. So if you get it too early, you can risk getting a false negative. And just be sure that it is IgM. If you are testing and you send IgG for measles, that's going to indicate prior exposure to measles or to the vaccine. So this is what we would use for immune status if we're doing a laboratory confirmation of immune status. But for testing, it's going to be IgM. For immune status, it's going to be IgG. What about newborns? I've had people ask about do we need to test newborns? Just like for most patients, it really routine testing is not indicated. You really want to only test if there is symptoms that are concerning for measles, but it is the same. It's you want to collect both the serum sample and the throat or nasopharyngeal swab. It's going to be the serum IgM and the measles RNA PCR for the swab. And then again, if you test too early with the blood, you can get that false negative, and so it would be recommended that if you are highly suspicious of a patient because they have symptoms of measles and that IgM is negative, it would be recommended to go ahead and test it again, maybe a little bit later. So I think this is kind of the meat of this lecture is, how do we manage these patients who've been exposed, especially without immunity, but, how do we determine, what does it change if they have immunity? What if they have partial immunity? So we're going to kind of go through those scenarios. But the overall kind of theme is going to be airborne precautions and isolation or quarantine per recommendations, and we'll talk what those recommendations are. I'm kind of using isolation and quarantine interchangeably. I think about isolation if they're in the hospital. I think about using the word quarantine if they're at home. It doesn't matter where the patient is. The isolation or quarantine is going to be the same. So whenever I'm talking about the number of days of isolation or the number of days of quarantine, it can be at home, it can be in the hospital, wherever that patient needs to be for their medical care. You're going to want to administer post-exposure prophylaxis per the guidelines, and we'll talk about what those are for each individual type of patient. And then, of course, it's really, really important that we're reporting to the health department as well as to your local and maybe hospital infection control so that we can track and follow these cases. Um, so talk a little bit more about some specific situations and how those three categories kind of play out. So for a lot of us on this lecture, we deal with moms and babies and pregnancy and delivery. So just a little bit on those specific situations. Ideally, you are able to identify these moms prior to their arrival to the hospital so that you can mask them and put them in airborne isolation as quickly as possible. If you are an OB or you're a family practice doctor who has moms that you deliver, if there's going to be someone else other than yourself caring for that newborn, maybe a different pediatrician or a partner, whatever it may be, it is vital that you make sure they are aware of any measles infection in that mom within 10 days of delivery. If a mom has measles within 10 days of delivery at any point, the risk of her child having congenital measles is there. And so even if she's not actively has measles at the day of delivery or she's not within that infectious window, if she's had measles within 10 days of delivery, her infant is at risk. The other thing that's going to be important is to discuss with the family the risk versus benefit of maternal and newborn separation. So right now, as far as what I could find through the CDC and other websites, it's not required to separate the mom and the baby. It's just said that there should be discussion with the healthcare provider, the family. If you have an infection control representative at your institution, sometimes it's helpful to bring them into the discussion. But you'd want to separate if the mother is within her infectious window. So again, that's going to be until 4 days post the onset of the rash. And so the day of the rash shows up is day 0. Anytime through 4 days, the mom's going to be infectious. So if she's had measles within 10 days of delivery, but she is past that 4-day infectious window, the baby doesn't have to be separated from the mom because she's no longer infectious. Once those 4 days are over, if they have separated, the baby can come back with the mom. Other things that sometimes can be thought about, or at least are worth discussing, is do you want to delay the discharge of the mom till she's no longer infectious? Especially maybe she has other children at home that are non-immune, or maybe other people in her household that are high risk of contracting measles, and you don't want to expose them. Can you keep that mom in the hospital? If there's someone else who can care for the baby who's immune, doesn't have measles, isn't at risk of contracting it, that's another option. You can send them home separately. So thinking about not only how are they going to be managed while they're in the hospital postnatally, what's the plan going to be once they go home as well, and who else is involved in their household. The other thing that is going to be vital is that you're going to want to give that newborn immune globulin. Doesn't matter if mom's in her infectious window. It only matters if she has had measles within those 10 days prior to delivery. Um, you're going to give the baby immune globulin, and you're going to want to isolate or quarantine that baby for 28 days after the last exposure, which usually, if you've separated, is going to be at birth. The immune globulin needs to be given within 6 days. So let's say you have a mom who delivered elsewhere maybe, and she then brings her baby in and you find out she'd had measles and it wasn't known at the time of delivery and the baby's 7 days old at this point. It is too late to give immune globulin, but you still want to put them in isolation or quarantine them for 21 days. So you'll see that that's a week shorter than the baby that got immune globulin, and that's really important. The immune globulin can actually prolong the incubation period of the measles virus. And so anyone who gets immune globulin, their isolation time frame is going to be longer than if you actually didn't give immune globulin. So some people may say, well, then I'm just not going to give it because then that can be shorter. The immune globulin, though, is there to try to prevent the infection. So it is vital that we give it to prevent infection, especially in these younger infant children who are most at risk for complications, especially those subacute encephalitis that we talked about. So we don't want to not give it so that we can have a shorter kind of isolation window. If the measles contracts measles itself, then you just switch to keeping them isolated or quarantined for those 4 days of their infectious window. Again, and also if the infant has measles, you do not have to keep them separated from the mom that also has measles. You can kind of put them together and quarantine them together. A little bit more on congenital measles. So again, congenital measles will be considered when the mother is infected with measles within the 10 days of delivery, and then the infant goes on to develop symptoms either at birth, so we consider that like a transplacental congenital measles infection, or has the onset of rash within 10 days of life. So mom has measles within 10 days of delivery, and the infant develops measles within 10 days of life. That's going to meet the definition of congenital measles. If a newborn or an infant develops measles after that 10 days, then that's going to be considered an extrauterine or postnatal infection. How do we kind of manage these again? These congenital measles, again, if mom's positive at delivery or within 10 days, you're going to give that baby immune globulin, potentially isolate from the mother. There's the dose of immune globulin for infant 0.5 mLs per kilo IM. We'll talk a little bit about, there is an IV option. We'll talk a little bit about that later. But for children and small children and infants, you're going to want to give it IM. And then again, if the baby is positive with measles, you can isolate them with the mother. A little bit about severity of illness. When we talk about congenital versus, postnatal or extrauterine infection, congenital, it is a spectrum, just like most infections, so mild to severe. Um, it isn't really dependent on whether or not the rash is antepartum versus postpartum on the mother. And the severe disease is going to be associated with more severe respiratory illnesses, any um, overlying bacterial infection, of course. And so it's just going to depend on how, mostly respiratory situation. Postnatal tends to be mild. Um, we think probably because there's some passively acquired antibodies potentially from the mother. So especially if she was vaccinated or she had early measles before those 10 days, so that baby tends to have some passive immunity from the mother. If it is severe, it's possibly due to a declining passive immunity. Um, and again, the severity of the disease is often related to the complications of respiratory illness and then the rare cases of encephalitis. Okay, so the next several slides are just kind of trying to put together some charts that talk about the person's age, what their immune status is at the time of their exposure, the timing of post-exposure prophylaxis and what it should be, and then isolation. So some of these are more straightforward and easier to follow than others. So we're going to start with children under the age of 6 months who have been exposed to measles. So obviously they are all going to have no immune status because of age. You're going to want to give them, again, that immune globulin within 6 days of their exposure and then isolate for 28 days. If you see them after that 6-day window and it is too late to give them post-exposure prophylaxis, then again, the isolation is going to be a little bit shorter, 21 days. If the newborn has confirmed measles, all you need to do is isolate 4 days from the onset of the rash. That one I feel is probably the most straightforward. I will say it's come up, well, why, if the baby has measles, why would you not still give immune globulin? And I think it's important to understand that you don't treat measles with post-exposure prophylaxis. So a confirmed case doesn't receive immune globulin. It's used to prevent infection in those exposed individuals. Once you've been infected, there's no indication to give immune globulin, or once you've confirmed infection. So what about exposure in children that are older than 6 months and non-immune? So we can divide this into 6 to 11 months and then those that are 12 months and older. So 6 to 11 months, these children generally are going to be non-immune again because of their age. If it has been within 3 days, because that child is 6 months and that is the earliest that you can give the MMR vaccine in these specific situations where someone's been exposed, you should give MMR. If you give the MMR vaccine within those 3 days, you do not need to quarantine that patient. If you see that patient and they're 6 to 11 months old, and you see them after 3 days alive, within 4 to 6 days, you can give them immune globulin, and then again isolate for 28 days. If it's past the 6-day window to give immune globulin, there's no specific treatment, just isolate or quarantine for 21 days. Okay, so the time at which from exposure that you see these children determines what post-exposure prophylaxis you give them and what the duration of their quarantine or isolation should be. If they are over 12 months of age and they are non-immune, they have not received any MMR vaccines, they have not had measles in the past. Again, if you see them within 3 days, you can give them the MMR and no quarantine is needed. If it is after 3 days, they are no longer eligible at that point for immune globulin. Younger children, younger than 12 months, they are more at risk for severe complications due to their more immature immune system, and they still have some maternal antibodies. And so we don't want to give them MMR because of the antibodies, but we do want to still protect them. So that's why under 12 months of age, we will give immune globulin through 6 days of life. But once they reach that 12 months, they're not as high risk. So we don't give them immune globulin. We just go ahead and quarantine them for 21 days. And then you want to, if they haven't had the MMR, you didn't have that window of 3 days to give it. Once the 21 days are over, you want to go ahead and give them the MMR to protect them from future exposure. So that one's a little bit more complex with a little more variables. 12 months is kind of the magic number of giving immune globulin or not. And then 6 months is kind of the magic number for catching them early enough to give them the MMR vaccine, even if it's early. And remember, if you give it before 12 months of age, you still want to give them 2 doses after they turn 12 months to follow the vaccine schedule. Okay, what about those children? They're older than 12 months. They got their first MMR vaccine, but they haven't had their second. What do we do with those? So again, if you catch them within the first 3 days of exposure and it's been 28 days from their first MMR vaccine, you can give them that second dose early, no quarantine needed. Okay. If it's after 3 days, they then kind of separated into whether or not they're a household member of a confirmed or suspected case or not. If they're living with someone who has, maybe was their exposure, who has measles, um, you want to quarantine your patient for 21 days. But you also want to go ahead and send an IgG titer, because if the IgG titer comes back showing that positive, showing that that infant has or that child has immunity, you do not have to continue quarantining them. They are protected from that household member and not at risk for developing measles because even though they've had one dose, they have a good immune response. So you would just quarantine till either you have that positive IgG titer or you would quarantine for 21 days if you do not have a titer or the titer is negative. If they are not a household member, so they're not being exposed at home, and they're over 1 year of age, they're less likely to get sick. They're less likely to have complications because they've had that one dose of their MMR. If you didn't catch them again early enough to give them their second dose, or it hadn't been long enough from their first dose, that 28-day window, you would just give them the MMR on time. So if they're over 4, you can go ahead and give their MMR again to prevent them from future exposures. And there's no specific quarantine for the child who's had one dose of MMR and who's not living at home continuing to be exposed. And then how about our adults who maybe we just don't know what their immune status is? I think that's probably for adults, they either know they've got their shots or they just don't know if they are immune or not. They don't know if they had measles, they don't know if they've been exposed before. So what do we do with those patients? Again, if you catch them within that 3-day window, you can give them MMR, and then they do not need a quarantine. If it's been after 3 days, again, we're going to look at, are they a household member of a confirmed or suspected case? If they are, it's the same as those older children. Obtain IgG titers and then either quarantine till that titer comes back positive, indicating immunity, or 21 days. If they're not a household member of a confirmed or suspected case, then you want to think a little bit more about other things like, do they work with children, or are they in a uh, work in a healthcare facility? In those situations, maybe you want to, figure out when can they get back to work? Can we do it as quickly as possible? So if the answer to those questions is yes, they either work with children or they work in a healthcare facility, again, you can get the IgG titers, quarantine until the titer comes back positive and they can return to work, or they would quarantine or isolate for 21 days. If they don't work with children or a healthcare facility, you can obtain the titer. It's recommended they just kind of get it through their PCP. They don't have to do it. They can just kind of stay at home and quarantine if that's possible. But if you're, wanting to get them, they need to get back to work or whatever, you can still do the same thing with them and do the titers. I didn't put anything up here regarding immunocompromised patients, but for immunocompromised patients, regardless of their immune status, you do want to give them immune globulin. the I think I have a slide down here that talks about the difference between IV and IM. So I'll talk a little bit more about that in just a second. So that's a lot. I think these charts are really helpful. I will say these charts I took from similar charts in the Red Book um, textbook. So those of you that, especially those of you that take care of children, are familiar with the Red Book. It's kind of the infectious disease Bible of what we use in pediatrics, at least. It has a lot of information about pregnancy and moms as well. And so those charts, I pulled information from their charts. And so that's I think, probably a really good resource that's about as straightforward as you're going to find, I think, on how to manage patients based on, again, age, immune status, time from their last exposure. But if I had to kind of try to summarize post-exposure prophylaxis, this is kind of how I think about it. If they qualify to receive the MMR, at least 6 months of age, 28 days from the previous MMR if they've had it, you can give the MMR within 72 hours of exposure. It will limit the risk of infection, hopefully minimize or modify the clinical course to be not as severe. It does kind of depend on its effectiveness, does depend on the exposure type. Was it a high risk exposure or a low risk exposure? It may not be as effective if you had like prolonged, intense, close contact with a measles case. But it's a good option to consider if the time course is met and the patient is eligible. Immune globulin you want to give to those patients that are eligible for that, again, within that 4 to 6 days of exposure. We talked about the second dose of MMR, giving it early, and we talked about MMR, the first dose, giving it early as well. You do not want to give MMR and the immune globulin at the same time. And remember, you don't want to give MMR to pregnant or immunocompromised patients. So the immune globulin, this is where I want to talk about the two options. It should be given the 0.5 mLs per kilo IM for all infants less than 12 months of age or any other susceptible high-risk contacts who are under 30 kilograms. So 30 kilograms is the max weight for the IM dose, which would make the max dose 15 mLs. For pregnant women without immunity, severely immunocompromised patients, patients over 30 kilograms, you're going to want to give it, it's recommended to give it IV. You can see the dose there. It's 400 milligrams per kilogram IV. And then again, you don't want to give it the same time as MMR, and you really need to wait probably 6 months to give the MMR if your patient received immune globulin. Vitamin A. So there's been a lot of discussion, I think, in the media and in the communities about vitamin A. There is some validity to vitamin A. It does not prevent measles, doesn't prevent measles disease. It does treat measles, but there is some relatively, I think, decent data that shows it is associated with decreased morbidity and mortality rates. The recommendation is one dose daily for 2 days, and you would want to do that, as soon as that patient is diagnosed and then the following day. I didn't put dosing on here. It's based on age, but it's pretty readily available if you go looking for it. So just a quick snippet on that. These are the resources, mostly from the health department, the Red Book, which I talked about, and then the CDC. I do want to go to questions real fast, but I want to show you real quick. Let me see if I can find it. Where did I put it? There is an algorithm that, no, I can't find it. There's an algorithm that was sent out. Oh, here it is. That was sent out from one of our local, I think, CDC providers, that was used in a outbreak in Illinois. And so we just kind of sent it out through our hospital, and I think we can disperse this. And I thought it was very similar to what we just talked about, and it's kind of in a nice algorithm form, and it's a one-page kind of practice advisory kind of bulletin. And so I think this is another good resource that we can kind of use, especially for mothers and newborns, or it is for mothers and newborns. So, start here. Has the mom had suspected within 10 days? Yes or no? How do you manage the mother? How do you manage the newborn? The one thing that is on here that we didn't really talk about, it talks about preterm babies. So for this algorithm, they are considering anyone under 35 weeks as a preterm infant. And it just says if preterm, isolate for prolonged periods. So unfortunately, it doesn't really give us any guidelines on what that means. I would say, if these patients are going to be in the NICU if they're under 35 weeks at birth, um, I would maybe think about keeping them in my NICU isolated maybe for their entire stay. If we think they may continue to have develop measles later, or maybe have a prolonged incubation period. I would have to probably be in discussion with our infection control folks to help guide that. But them being more at risk, having a unit full of patients that are at risk, it wouldn't be unusual to maybe consider, or I don't think it would be out of the ordinary to maybe consider keeping them in isolation for their entire ICU stay. But that was probably the one difference that I saw on there that was added. Unfortunately, it doesn't give us a ton of um, uh, direction other than just saying consider more prolonged period of isolation. So I think we can get that out to you guys as well. But I kind of want to open it now for any questions I have. I said again, Dr. Robinson, she runs our newborn nursery and our family birth care unit. So especially if you guys have questions about, how are we managing these patients? Where are we keeping them? I want to go ahead and open it up at this time for any questions you guys may have. And Kelsey, I can't see the chat.
Dr.
I don't know if
Cooper, I
there's
added in the
anybody
chat
in the
that
chat.
they did. So several people wanted the algorithm, and I had them add their email in the chat. So if you would like the algorithm or the slides or the recording, I'll probably just send all three of them together at once. So if you'd like any of those, just add your email into the chat and I can get those to you guys later this afternoon.
Dr. Robinson, do you want to just maybe speak a little briefly on kind of the plan for moms and babies that you guys have for the newborn nursery and the family birth center?
Sure. We are, as mentioned in your presentation, if we can identify moms that are at risk or exposed ahead of time and mask as soon as they come in the building, that helps minimize the exposure to other people in our lobbies and the healthcare facility. I will tell you that is played out better in theory than in reality. In reality, these patients tend to just walk in. And so having your sort of frontline um, reception and staff kind of be aware of what an active measles rash looks like so that they can sort of intervene we have masks at the entrance also. And then once they're in the facility, and if we are delivering imminently, we're going to have conversations about separating if necessary. That's going to be a shared decision making conversation with the family. We have a plan in place if we do need to separate, and that could be on a voluntary, like mom wants to separate, or if mom is extremely ill and we need to separate and the baby doesn't need to go to NICU, we have a separate isolation room where we can care for the baby one-on-one. The other important thing is if you have more than one baby in this situation, they also have to be isolated from each other, which hopefully we won't encounter that many at a time. And then we will just take that on a case by case basis, using, really good quarantine and universal precautions. The other thing that we have decided is that in these babies, we will not do circumcisions in the newborn nursery. We're going to have to just defer those to the outpatient setting, more than likely if that becomes a question. Just based on their infection probability, and then just logistically how to get those performed safely and in isolation. We just decided that was a better deferring that to the outpatient setting, if that's even a situation where it's wanted. Um, we You also need a separate, if mom is going to express breast milk, and then you need a separate refrigerator where you can sort of safely. We had that prepared during COVID as well, where we had a separate breast milk refrigerator where we could store breast milk, and a plan for how to transfer that to clean bottles and then store that for use for the baby as needed. Any other specific newborn related questions? Or even family care unit related questions?
If there are any questions that you think of down the line or later on, you're welcome to add them in the chat or email them to me, and I can try to get your questions answered through Dr. Peepcorn or Dr. Robinson. Thank you guys so much for your presentation. Had a really positive response, so I'm really excited about this and to share it with those that weren't able to be here today as well. Just while you're thinking of questions, I will let you know I'm going to post the link to the evaluation in the chat. So if you'll refer back to the chat, click on the link to the evaluation, and I will get your certificates emailed to you. If you have any questions, please reach out and let me know. We are happy to help in any way that we can.
Thank you, everybody.